Hello, I'm Dr. Guy Yatros, one of the founders here of Dental Sleep Solutions. Thanks for tuning in to Dental Sleep Medicine Insider Magazine. You know, a lot of you have heard us talk over the years about how dental sleep is a part of your business you can start doing in your offices and doesn't require a whole lot of financial investment. And that's still true. But with that being said, I'll have to tell you, I'm really excited. I got one of my newest toy. I haven't had a dental toy in many years. And I now am the proud owner of a OP300 CBCT. It's an instrumentarium unit that I tell you, it's really changed the way I'm doing dental sleep in my practice. A lot of the things that I took for granted before, trying to guess about airway, guess about nasal patency, guess about TMJ issues, we can now tell a lot more information with my CBCT unit. You can see it makes a lot of cool noises when it impresses the patients when we do it. We have a full field of view. If you're going to get one of these units, you want one that you can, you know, sit down and look at the entire airway, and you can see the kind of images you can get, and we can see what we call the minimal cross-sectional area. We can see incredible things like this person here whose nose has obviously been damaged in some ways, and it also has a small airway, as you can see. And that may look familiar as you look at me here, because that's my image there, and we can see what's going on with my nose and the fact that I'm having some concerns that I'm probably going to address down the road. So how do I use this in my practice? Well, again, what are we looking for when it comes to dental sleep medicine? What are the things that we're trying to analyze anatomically? We're looking at the size of the tongue, the neck size, retrognathia, where is the hyoid bone in relationship to the mandibular arch, the volume of the airway. We could do that with CES, but we can only get one dimension. Now we can get the minimal cross-section area of the airway. Tonsils, adenoids, oropharyngeal crowding, tissue collapsibility really is the only factor that we can't tell and the body position with the CBCT imaging. How I use this in my office is every patient that we see for dental sleep medicine. Again, if you're going to get a unit, you want one that captures the entire airway from the trachea up into the nasal cavities all the way back to the TMJs, because we're wanting to evaluate them. I really feel this is a game changer in a lot of ways in my practice, because there's a lot of indications. For newer dentists to dental sleep medicine, I think one of the biggest things that it does is it can help you with your screening process. A lot of patients are resistant to getting a sleep test, or they want to be able to see what we see when we're going on. And when we have a situation like this where you can see a narrow airway versus an open airway, as you look at the two photographs here, and what we can even do is color that for a patient and show, look, we're looking for a big open airway. Here you are, a wide awake. This is best your airway is going to get. If we see something that looks like this with the airway being narrow, we have something we call the minimal cross-sectional airway. And as we look at those side by side, we can see the differences, and the patient can readily see why they may be more susceptible, and it can help us with gathering the information to see if we think that they're at risk for sleep disordered breathing and get the test. We can even look at some numbers from some tests showing that a minimal cross-section airway of less than 110 millimeters is something we might want to be concerned as a risk factor for sleep disordered breathing. So how do I use this mostly in my practice? Because most of my patients have already been diagnosed, is I want to be able to look for some things that maybe I couldn't see before. Unless you're more talented than me and be able to get a mirror back behind the soft palate and look for adenoid tissue, or you want to use a nasal scope, we are now seeing patients that, wow, they have some hypertrophied adenoid tissue that can affect whether these dental devices may or may not be successful. So as we're screening our patients and we're trying to make a decision as to whether a dental device is going to be successful for them, we want to look at things like their turbinates. So how are we going to see images of these of their airway? And we're looking for big black open airway on their noses, and we see something that looks like this with the airway, the deviated septum. But as you look at the one side with the black openings, you can see a lot of air can go through one side, but the other side not on this particular patient. And that patient will have a very likely more difficult in adapting to a dental device, or at the very least we want to know about this, so we may select a dental device that will be more applicable to that patient, allowing maybe some oral breathing as a mouth opening as one of the options. We're moving the jaw joint to a forward position and keeping it there all night. We're putting a little bit of strain on the TMJ, and we certainly want to see things like this. If we didn't have an image of this patient before and we find out that, that they had degenerative joint disease, we like to know that prior to doing our mandibular advancement device or dental sleep therapy. So we're looking for fossil changes, we're looking for abnormalities in the jaw joints. And one of the reasons I was resistant to this over the years was that, the radiation involved. And so, we would take Cephs and different things to look at the jaw joints and other ways of evaluating the nose. But here's the thing that really convinced me of this, is now a full airway, a 13 by 15 image can show everything we need, even show the teeth to enough degree that we're happy to be able to say that the teeth are stable enough for a dental device. And we're looking at what's called 32 microsieverts of radiation, which is barely more than a digital pan. A digital pan's 20. So I mean, it's in the same ballpark. It's far, far less than our old FMXs that we used to take. And so we're just getting so much more information now than we used to, with far less radiation than we used to even give our patients for just a traditional full mouth series. So I think it's a great instrument to have in your practice. It can be an integral part of doing a better job of dental sleep medicine. And insurance covers this. We're starting to bill medical insurance, so we can get some extra contributions from the third-party payers. I believe you're really doing the standard of care if you're doing these on your patients. And I also have found it's helping me with my referrals to my medical community, my ENTs in particular, and it's overall becoming a very profitable investment. You should consider looking at adding CBC to your practice. A lot of you have it already or thinking about getting it for implants and other uses, and it's just yet another reason why this technology is really growing in dentistry. Thanks a lot for reading this episode of Dental Sleep Medicine Insider Magazine, and from us here at Dental Sleep Solutions and DS3 Software, have a great day.